Okay, hi guys. So now we're going to be talking about lymphadenopathy. Now there again a lot of things that you need to know in this, but if you can understand it, the questions can become very easy. So let's start with this is basically the content that we're going to be talking about. So introduction. Now basically when we're talking about lymphadenopathy, we know that it's basically the enlargement of the lymph nodes. Now this can either be due to some kind of reactive lymphadenitis, such as due to for example like infections or we can say like lymph node hyperplasia due to B and T cells or histiocytes, which can be caused by like viruses, bacterias, metals, even drugs can basically lead to it, or it can form an infiltrative disease, which can be basically due to metastasis or lymphomas, for example. Now, obviously, they can be painful, they can be painless, generalized, local, hard, and soft, which I'm sure you already know about, like what leads to pain, which ones are painful, which one are painless. But the more important thing to know is that if they're soft and painful, probably it is an infectious etiology, such as it could be lymphadenitis. Now, if there's like a sudden generalized lymphadenopathy, normally it is due to an HIV infection. They're most commonly causing like a sudden generalized lymphadenopathy. If it is rigid and it is non-painful, this normally we have to rule out a tumor. Always we have to rule out a tumor. If it is a lymphoma, leukemia, is it some kind of secondary metastasis? And for this reason, we have to do the biopsy of the particular lymph nodes that are basically enlarged. And if they're hard and painless, we have to do biopsy. Okay. So let's go to our first disease, which is basically reactive hyperplasia. Now, whenever we're talking about reactive hyperplasia, this is basically a non-specific inflammation that leads to an enlarged. You have to remember the major, we can say, words that you really need to remember, or keywords would be like tender, painful lymph nodes. In which case would it be painful? So reactive hyperplasia would basically lead to a painful lymph node, and mostly it is a follicular hyperplasia. I will show you the classification later. So we can have like para follicular hyperplasia and follicular hyperplasia, right? So based on those, we can have the classification. But in reactive hyperplasia, mostly it is due to the follicular hyperplasia. In the case that we talk about morphology, which is, and follicular hyperplasia is basically the proliferation of the germinal centers, okay, within the lymph nodes. Now, a major thing that you also need to remember is about the morphology. So it can be it is basically enlarged. It is basically it can be spontaneous, or mostly it is painful on touch. So this is morphology. But another thing that you can also mention is that they are swollen. Okay, they can be gray, red, and may contain pus if the neutrophils are prominent, right? So we know dead neutrophils form pus. So there can be presence of pus as well. And if there's like an overlying skin is normally red and swollen. Now, one thing that also is important is in some cases what happens is that in the lymph node, when there's a presence of, we can say, pus, okay, or the purulent infection that is present, it starts to penetrate the capsule and then towards the skin, and it generates this kind of drainage onto the skin. Okay, so they drain the sinus onto the skin, which is actually healing by a scar. And this is actually seen in like chronic cases where the lymph nodes are enlarged for a longer period of time. Now, reactive hyperplasia can be either localized, which can be seen in the case of primary syphilis, for example, or it can be generalized, for example, in the case of systemic infections. For example, when primary syphilis becomes secondary syphilis, it becomes more of a systemic infection, and so it basically becomes a more generalized infection, right? So this is basically about the, we can say, reactive hyperplasia of the lymph nodes. Now, next we can talk about granulomatous lymphadenitis. Okay. Now, before we go into the detail, I want you to know what a granuloma is. Because if you cannot define a granuloma, then this can be very difficult. So granuloma is basically a when there are groups of modified macrophages which are basically called epithelioid cells with or without necrosis. That's why you say they're caseating or non-caseating. Okay. So now in this case, when we're talking about granulomatous lymphadenitis, it is basically a specific granulomatous inflammation with granuloma formation within the lymph node. Like in the picture, you can see even in tuberculosis, for example, tuberculosis infection, when it reaches the lymph node, this is something that we can see. It basically produces this granulomatous lymphadenitis or lymphadenopathy. Okay. So it can be obviously infectious, which we already know, for example, TB, or non-infectious such as sarcoidosis. So in sarcoidosis, we can see this granulomatous lymphadenopathy, and this is basically we can see the characteristics like fever, weight loss, erythema nodosum, or histologically it resembles TB. So on the picture, what you can see is very similar to what we can see in sarcoidosis as well. But furthermore, we need to mention other diseases as well, right? For example, if you're mentioning an example, always remember to at least define one of them or give some information about them. Don't just say the names, right? So, for example, if you're talking about TB, it's good to mention that these are giant cell granulomatous lymphadenitis with caseous necrosis. Okay. If you talk about syphilis, it is ulcer durum plus lymphangitis plus indolent bubo. Then for purulent infections, for example, atypical mycobacterium, cat scratch disease can lead to it, or tularemia, for example. For toxoplasmosis, we can talk about small epithelioid granulomas. And then we can have, for example, mesenteric lymphadenitis seen in the case of Yersinia, for example, or Whippler's disease can also be talked about. Or we have, for example, non-infectious granulomatous lymphadenitis seen in, for example, beryllium poisoning or silicosis, right? So these are basically some of the examples that you can also mention when talking about granulomatous lymphadenitis. But basically, when you're talking about granulomatous lymphadenopathy, just remember that here we have the formation of granulomas, okay? Great. Now we can go into acute lymphadenitis. As I said that, the granuloma, the lymphadenopathy that can be formed, or lymphadenopathy that is present, it can be due to infections. And this can be acute lymphadenitis, or it can be due to chronic lymphadenitis, right? In acute lymphadenitis, normally we're seeing these painful lymphadenopathies, right? And they are localized normally, and they're very painful. So they're localized and painful, mainly from bacterial infections. They can often involve like the tonsils or inguinal nodes and can lead to lymphogranuloma venereum. In the microscopy, we can see these large reactive germinal centers and neutrophils within the lymph nodes. For example, in the case of like pyogenic infections or pyogenic organisms, we're able to see that there's accumulations within the lymphoid sinuses and in mild cases. Or they can lead to like follicle central necrosis, where the node, the lymph node actually converts into a bag of pus. Okay. So this is basically also seen in when there's an acute lymphadenitis. Then obviously this is basically localized and painful we're talking about. Now we can talk about generalized painful lymphadenopathy. In this case, we can see that this is normally due to like viral infections, right? Bacteremia, and normally due to systemic diseases such as systemic lupus erythematosus. On the table next to this, you can also see some of the causes of lymphadenopathy, but you don't need to know all of them. Just know some examples, and that would be good enough. Okay, then we can talk about chronic lymphadenitis, in which we can again see lymphadenopathies. Now, these are normally painless lymphadenopathies with three possibilities. So there can be three different differential diagnoses that can be given. Either it can be chronic inflammation, for example, in an autoimmune disease. It can be due to a metastatic carcinoma, okay, or it can be lymphomas, like malignancies, for example. So they can be localized, painless lymphadenopathy, or generalized painless lymphadenopathy. So localized painless lymphadenopathy is that when the lymph nodes are draining, like primary cancers, for example, in breast cancer, we know that the axillary lymph nodes are the ones that are draining it. And for example, in the case of Hodgkin's lymphoma, we can see this. Or in the case that we talk about generalized painless lymphadenopathy, in which we can see majority of the acute and chronic leukemias, for example, and lymphomas can be talked about. But do remember that when we're talking about the acute and chronic leukemias, here we cannot talk about HCL. Okay, so we don't talk about HCL in the case of generalized painless lymphadenopathy. And when we talk about lymphomas, for example, we can talk about follicular B lymphoma, which also leads to, we can say, generalized painless lymphadenopathy. Then we have like now I was talking about how we can morphologically classify the particular lymph nodes and their enlargements when talking about lymphadenopathies, right? So for example, we can have follicular hyperplasia, paracortical hyperplasias, and then diffuse and mixed, for example, and sinus histiocytosis. So let me give some explanation. So most of it is already written over there and you can read it yourself. But and basically that would be enough. But here again, I'm mentioning that when you talk about the drainage of the, when you're talking about, for example, B cell antigenic response in the case of follicular hyperplasia, there's an expanding lymph node follicle, especially the mantle zone and the germinal zone. And this can be seen in rheumatoid arthritis, for example, toxoplasmosis, and even early HIV. So the CD4 and dendritic cells, for example, and here we can see like tingible body macrophages. So tingible body macrophages like B cell debris from the apoptosis. Okay. Furthermore, we can talk about paracortical hyperplasia. In this, the T cells antigenic this is a T cell antigenic response. The follicular hyperplasia was B cell antigenic response. Paracortical hyperplasia is T cell antigenic response, and it is expanding the paracortex. Now, what diseases can lead to it? For example, Epstein-Barr virus, in the case of infectious mononucleosis, or systemic lupus erythematosus can be seen. Then we can talk about diffuse. Now, this is basically when the basic architecture or the basic, shape of the lymph node is not visible anymore. So it's completely distorted because the follicles and the germinal centers now cannot be differentiated. Then we have mixed B and T cell hyperplasia, in which you can see that there is an expansion of both follicle and paracortex. This can be seen in the case of, for example, cat scratch disease or toxoplasmosis, for example, can basically lead to mixed B T cell hyperplasia. Then we can finally talk about sinus histiocytosis and reticular hyperplasia. This is when the macrophages are actually responding and the expansion of the lymph nodes, endothelial cells like the sinusoids, uh, endothelial cell sinusoids and macrophage infiltrate. And this can be classically seen when you're talking about the cancer draining lymph nodes. Okay. So this is basically about our chronic lymphadenitis. You'll actually study more in detail about this in the lymphadenitis question. So make sure you also watch that, because in that you'll actually understand how it's happening and why it's leading to the lymphadenopathy. But again, lymphadenitis can lead to lymphadenopathy. Okay. Now, next we can talk about some of the more uncommon lymphadenopathies, such as I already mentioned that in sarcoidosis we can see it. And then we can talk about the Castleman's disease. Now, in Castleman's disease, now these are very rare, but they can, however, ask you because there's some like classical features of this kind of lymphadenopathy. For example, in Castleman's disease, they can actually have two forms, hyaline vascular type and plasma cell type. In hyaline vascular type, very, very important is that it looks like an onion peel. And plasma cell type is like a mixture of immune complexes and fibrin, and it basically can be leading to anemia, polyclonal hypergammaglobulinemia, and hypoalbuminemia. Okay. Then we can talk about solitary. So these are the basic two types, two morphological types, but they can present as solitary or can be multicentric. So when you talk about solitary, we normally see it in the mediastinum, neck, meninges, and they're up to 10 centimeters. In multicentric, They're almost always like plasma cell type, and they basically lead to splenomegaly. Okay. Next, we can talk about histiocytic necrotizing lymphadenitis. This is a idiopathic young woman in Asia. It is painless, and it is cervical lymphadenopathy plus fever. In the histology, we can actually see necrosis with a lot of macrophages present. Okay. Now, Rosai Dorfman disease is one of the one that they can actually ask you. So make sure you really know about this one. So it can be idiopathic. It is painless. The main thing that you really need to remember is if it's painless, what is the reason it is occurring, what infections can lead to it. Okay, if it is hard or is it soft, that's basically the morphology. So here we're talking about idiopathic. It's painless. It has massive lymphadenopathy and bilateral on the neck. It is always bilateral. So remember that, and it is present on the neck. In the histology, we can actually see these macrophages in the sinuses and in the cytoplasm, which is intact with intact lymphocytes, and so called it is empyropolysis. Okay. Next, finally, we can move on to the cancers. So in the case that we talk about, like the cancers which are basically leading to it, we say that either it can be a metastasis or it can be a primary cancer, and that's how I have classified them. Either they can be a primary lymphadenopathy or they can lead to a secondary lymphadenopathy. Now, frequently what we've seen is that when a particular we can say lymphadenopathy occurs due to cancers, we can see that they're frequently fused together and they form packets of the lymph nodes. And metastasis is actually the lymph nodes become much harder than in the case of primary lymphoid organs. Primary are often generalized, like when there's a primary infection, for example, if we're talking about Hodgkin's lymphoma, as I've given an example over here, um, those are actually often generalized, while when we're talking about metastatic, they are often like in a single direction, which we know here. What I'm talking about is basically the sentinel lymph nodes, right? So so basically when we're talking about these Hodgkin lymphomas, for example, what is the most important thing you would need to do? Painless, soft and elastic, lymph node enlargement, and then the staging is something that is also quite helpful. They can ask you, how do we stage them? Is it single or in a group? Is it more than 1 centimeter? Is it above? It is below or above the diaphragm? Is it in both, for example? Is it only above? Is it only below? Is it in both of the places? So it basically depends. And both, is it on both sides of diaphragm? Is it widespread to extra lymphoid tissues, for example? Now, another example can be non-Hodgkin's lymphomas. This is probably like 75 to 80% of the lymphomas, and 3 by 4 are basically arising on the lymph nodes. They cause enlarged and painless lymph nodes. And the thing is that the most concerning thing is that they can cause compression of the surrounding structures and can lead to infections. Then we have chronic lymphoid leukemia. In this case, this is basically a monoclonal proliferation of small lymphocytes, B cells mostly, and leading to lymph node enlargement and splenomegaly. And the germinal centers in the lymph nodes are normally completely destroyed due to the infiltration by the lymphocytes. Okay. In the case that we talk about the secondary lymphadenopathy, I know that you probably understand that it is due to metastasis, right? In this case, it causes an enlarged and very hard lymph node. Okay. And in this case, we know that sentinel lymph nodes are the most important because that's where the cancer drains. This is the first lymph node that it drains to. If I want to know if the cancer has spread or not, what would I biopsy? I would biopsy the first sentinel lymph node, right? And in this case, we'll be able to see that yeah. So breast cancers, for example, in the axillary lymph nodes, these get enlarged, and it is very important for staging, because we know when you're talking about TNM staging, this is sentinel lymph nodes play an important role, as biopsy of the sentinel lymph node is performed on certain cancers, helping us to actually guide specific therapy as well. Not just that we can do staging, but it also helps us with therapy and the prognosis. Furthermore, another node that I would really suggest you know is that Virchow's node, and in this case, these are basically lymph nodes that are present in the left supraclavicular fossa, which is basically the area above the left clavicle, and it takes its supply from the lymph vessels in the abdominal cavity. So it's taking the supply from the abdominal cavity, because of which it is very important for gastric cancers as well. Okay. So that's basically everything you need to know for this question. And something that a lot of people who went for the exam said that people who had, for example, Statisky, he would really emphasize on you knowing who's what kind of in which cases would you see painful lymphadenopathy, in which cases would you see painless. We know that normally if it is due to if it's a cancer, if there is metastasis, it is normally painless. Painful would be, for example, in the case of reactive lymphadenopathy or due to some kind of lymphadenitis, for example, we can see like painful lymphadenopathy. Or in the case, for example, we can say, or he would ask you like, what does reactive mean, or what is infiltrative? Like I've already mentioned, infiltrative, I know you probably understand that infiltration, just the infiltration of those cells which are forming the cancer, right? So those are basically infiltrative diseases, or it can be neoplastic or non-neoplastic. Again, this table can be very helpful over here. I would suggest that you really go through this table properly because this was in Parthu's presentation. So I think like if you get her as your examiner and if you get this question, she would really appreciate if you know all of what she said in her presentation. Anyways, I hope it was helpful and all the best.